This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, I'm here with yet another very tough case, and these are the cases which fall into the category that how I wish I had another chance. Well, this is all about how appearances can be deceptive. Now, she is a 75-year-old lady who has this brown nuclear cataract. Looks to be grade 4, grade 5, and I've operated hundreds of such cases and done phaco, and well, so I thought I should not be a major problem. I should be able to do the surgery quite easily. Intraoperatively, I felt something else. So let's dive in. The surgery is being done under posterior deceptive anesthesia, and so I'm expecting a fairly long procedure, so I want the patient to be comfortable. The 2 side ports are done, and I'm staining the capsule. Mind you, the visualization is not great. These elderly patients, the cornea would not be very clear. And especially in these dark brown or black cataracts, the visualization again is hampered because there's no contrast available as compared to a white cataract or any mature cataract. So visualization is going to be a challenge. And as I have been mentioning in my previous case series, having a larger axis is beneficial when you're dealing with these ultra hard cataracts. So that's my goal. So I aim to perform at least 5.5 millimeter of rhexis, not less than this. So aid visualization, the staining of the capsule is very important, and hopefully it has stained well, and I'm got a rhexis which is of adequate size. Gentle hydrodissection is being done just to ensure that all the corticocapsular adhesions are broken. It's important to be mindful that the bag would be extra distended because of the large nucleus. There's hardly any cortex and epinucleus, so the amount of fluid which we use for hydrodissection has to be very minimal. Multiple areas of decompression should ensure that there is no building up of intracapsular pressure. I confirm the nucleus mobility by rotating the nucleus. It rotates fine, and the good part about all this is that the pupil is well dilating. There's no evidence of any cross zonular health, and that is one of the main reasons why I thought phacoemulsification is a good enough option for me. But one major challenge which I am noticing now is about the visibility. You know what? The pictures what we are seeing now is after doing some color correction during the video editing. But actually in the microscope, I was seeing something like this. Let me turn off all the color correction which I've done, and this was it. This visibility is not so great. So that was my biggest challenge. Now I decided to do a phacoemulsification because pupil was not an issue and zonules were healthy. So, but now I'm encountering that the visualization is not so great. So if you just turn off the color correction, you can see everything looks to be a little bit hazy. And we are seeing well in the video simply because I've added a lot of contrast and I've increased the brightness. That's the reason why the visibility is great. But nevertheless, by doing this color correction, we can see well so that all the surgeons can see and learn better. That's the idea. The choice of nucleotomy now. Well, you must have all guessed by now that whenever I see these dense cataracts, my go-to procedure is always the divide and conquer 4-quadrant technique, simply because while chopping and lateral separation, I end up having a little bit of stress on the bag and the zonules, and that can be mitigated significantly if we do the sculpting and trenching, because we're eating of the core of the nucleus, and that really breaks the hardest part of the nucleus, and then the lateral separation maneuvers are going to be much more easier and less stressful on the bag and the zonules. So as I typically teach, stabilize the nucleus with my second instrument, use adequate power to do the trenching. This is what I'm trying to do now. You can see that there's hardly any push on the nucleus. The nucleus is just shaved off effortlessly using the phaco energy. Now, the Alcon machine has this torsional energy, which is extremely efficient in cutting, and it doesn't generate much of a heat. So the major concern for us when you're using this continuous phaco power is the wound burn, which is very common in some of the machines which are using only longitudinal energy. So with this technology of torsional energy, there's a bigger advantage that you can cut even the hardest of the cataract without causing a significant thermal injury to the wound. So that is one advantage, and we should take advantage of this cutting ability. That's what I feel. Couple of strokes later, I rotate the nucleus using the bimanual way of rotating the nucleus, and the trenching is continued. You can notice how stable the nucleus is when I'm doing the trenching. It's literally the ultrasound energy is shaving off the nucleus without causing any tremor or push on the nucleus. And this is the beauty of the sculpting. It's very controlled, and at no point am I feeling that things are not under control. The only caveat or the downside is it is going to take a little bit more time compared to a direct chop technique, but I think definitely this is much more safer and reproducible even for a lesser skilled surgeon. Again, the understanding the concept is very important. So you are stabilizing the nucleus with the second instrument and using the right amount of energy to cut across this dense nucleus. It's almost like a dark granite, and you can still go through it effortlessly if you use the right amount of energy. In this case, the power is set at 90% and we can efficiently cut through it. So nucleus is kept on rotating until I have the sufficient depth. And the depth which I'm aiming at is 90%. So how do I judge the depth here? In this case, the only parameter which I go is, looking at the striations as they disappear and there is a change in the color of the posterior plate. That would indicate that my depth is adequate. These horizontal striations will disappear after some time, that is after you reach a certain amount of depth. And then we are closer to the posterior plate, but I still continue to do the trenching until the color becomes really dark, and at that point we know that the plate is really thin. The goal is to have as thin a posterior plate as possible because that ensures the lateral separation to break the posterior plate with least amount of physical force. The trenches are sufficiently deep, I believe. I'm not able to see any horizontal striations now. It looks like we've got the thinnest possible posterior plate. Maybe it's about 85 to 90% depth. And now is the time I thought I should attempt lateral separation. So I'm exchanging my second instrument with a long blunt chopper so that I can have a very good reach. The most critical aspect of doing lateral separation is that we need to place these two instruments right at the bottom of the trench. That is, we should be literally caressing the floor of the trench, and then the lateral separation maneuver will be less stressful. So the phaco tip in my right hand and the long chopper in my left hand, the lateral separation maneuvers are done. And it might require a couple of attempts before a full thickness crack is achieved. The nucleus is then rotated and the same maneuvers are being continued. We need to be patient and ensure that our movements are not so aggressive so that they can stress the bag. So again, patience is the key. Three cracks are done, and for the last crack I need to go back and fill in the chamber with OVD, and then again I'm going to use the phaco tip and the long chopper, and then a little bit of forceful separation is required and we have a full thickness crack. So now we are successful in creating 4 quadrants and time to emulsify. Until this point, I thought that getting them to break is probably the most difficult step, and I have achieved this, and now the job is almost done. Well, it is true in parts, but I'll just demonstrate how difficult the subsequent steps were as well. Before I start quadrant removal, I'd just like to pause here and show you the energy which I'm using. I've set it at a maximum of 80% energy here simply because this lens is too dense. And these are the flow rate in the vacuum. The torsional energy is set at 80% and it's in set in pulse mode. Now, as the fragment is pulled out of the bag for emulsification, now I'm overwhelmed by the almost gigantic size of this fragment. It's very black and very dense, and also it's quite huge. So my concern is there is a lack of space here, and I might be risking the corneal endothelium during this fragment removal. So my primary focus is to minimize the lens chatter as much as possible. So for that, I'm going to use a very controlled delivery of the phaco energy, which is controlled by my foot, and the second instrument is always going to be on top of the fragment. So let's see how it is done. Being slow is the key here. You don't have to be overwhelmed, and this is the moment where surgeons can become anxious and try to finish off the job in a flurry. It can be done. If you use more energy, this thick fragment can also disappear in a fraction of a second, but that would cause a lot of collateral damage to the corneal endothelium. So the mantra here is to be very slow. That's what I'm doing here. You can see the fragment is literally dancing around the tip, and it looks like it's going to take ages to finish this fragment, but it's worthwhile. And because it is taking so painfully slow, at this point I must confess that I was having second doubts, and I was thinking that maybe this was not the case to perform phaco. Maybe I should have done manual SICS in this case, and that feeling definitely crept in now. But now I felt it is too late to convert because we've got large fragments, and if I can control the fragment fluttering inside the chamber, then it would be all good. That's what my thought is. Slowly and steadily, the fragment is being chewed on. After every fragment removal, OVD has to be replenished religiously. The dispersive OVD goes in first, which coats the endothelium, followed by HPMC underneath it. Similarly, the next fragment is pulled out of the bag, and in the same way, a controlled emulsification of the fragment is being done. The key to achieving a clear cornea or minimizing the endothelial damage is to have as much of a less of a turbulence in the antechamber as possible. So that is the key here. And although the power is set at 80%, you can see that I'm barely using the maximum energy. I'm usually hovering around between 30 and 50% of energy, and it is controlled by my foot. The energy delivery is set in a linear fashion. If we use more energy, we can emulsify the fragments faster. There's no doubt about it. But the price which we pay is we induce a lot of lens chatter and turbulence in the antechamber, and that is going to cause an effect on the corneal endothelium. So there's a reason why I think being very slow and controlled is the key to deal with these things. So there was a thought for me to, can I chop them to smaller fragments? But I thought manipulating this dense fragment with half the bag empty might be a little bit tricky. So I continued emulsifying these large fragments, and eventually it was heartening that I could manage them without causing any significant turbulence in the antechamber. There's hardly any cortex there to remove. The chamber is filled with OVD and the lens is implanted into the bag. So that's it, the case is done. But let me go back and summarize few key points here. Sometimes our estimation of the nuclear density might not be accurate, as happened in this case. So this was probably one of the most difficult or hardest cataract which I have encountered. It was not so apparent at the slit lamp, but once I started to sculpt the nucleus, I was overwhelmed by the enormity of the thickness of the lens, and which was more evident actually once I removed the fragment from the bag. And this fragment was very huge and extremely thick and hard to emulsify. It was seeming that it was going to take ages for me to emulsify this, but if you have patience and if you can control the parameters, you can achieve and break down this granite rock-like lens as well without causing any significant stress on the endothelium. Now, one parameter which we have to look at in this case, I just exemplify from this case, is that look at the lens thickness. The lens thickness can be variable, and relatively how big it is compared to the antechamber. That's one point which we need to correlate, and maybe that would have given me a better idea. And these are the post-op pictures, and the first day there was some corneal edema, and eventually it clears off. By the 5th day, the cornea is clear, the patient is happy. Well, to conclude, I must say that I would have lost few of my myocardial cells during this procedure. It was stressful, let me confess about it. But if we are clear about your concepts and if you are using the right principles and the technique, you can deal with this situation and come out of it quite successful. So that was it. Thank you for watching and hope you found this helpful.